We'll start with introductions because we are sort of in this rather bizarre line. Do you want to start with an introduction and then we'll go along?
Let me know when you're ready.
You can now.
Good afternoon, everybody. I'm Carolyn. I'm Carolyn Robotham, and I'm the bereavement midwife, one of the bereavement midwives from Kettering.
I'm Dr. Kirsty Harris. I'm the principal clinical psychologist for the Maternal Mental Health Service.
Trudy Robertson, I'm one of the psychological therapists in the maternal mental health team.
Rachel Moss, I'm one of the bereavement midwives from Northampton General Hospital. I also work with another colleague, also called Rachel Searle, and she's unable to be here today, but we do work together.
And I'm Lisa Drummond. I'm the bereavement midwife at Kettering Hospital.
And there's a lot of the rest of the team in the audience, but we won't introduce everybody. But I'm really grateful that we've managed to get everybody together. I think this is the first time we've all been in a room, an actual real life room. So although there's a long line of us, I'm pleased to have everybody together. So we're hoping that there'll be some people online, and then obviously there's you guys here, but we're trying to split between the two. I don't think we've got any housekeeping because you've all been here since this morning, so I think you all know your way around and tea and coffee and everything like that. So obviously there's been the presentation this morning by SANS, which was really grateful for them doing that for us. And then we're also now going to look at pregnancy after loss, which Jane was talking about earlier. So we're going to be thinking a lot about that today, and partly because that's a lot of the work that Trude and I do, and obviously bereavement midwives would do as well. Okay, next slide, I think. So we are going to talk about obviously maternal loss and baby loss, and for us that's any type of loss. So I've heard some people go, oh well, it was early, or it was this. It doesn't matter. You don't need to caveat any of your losses. A loss is a loss for us, and I know Sam's were talking about that as well. We do know that we're discussing things that can be difficult. There can be a lot of emotion in the room. Do let us know if you need to talk. Obviously, we're all here to talk, but particularly if you are online, put something in the chat or put your hand up or whatever, and one of us can call you. It doesn't need to be a a group chat or anything like that. Okay, next one, please. So we've started to talk about baby loss and what it is. So there's slight differences in what we do. We as a maternal mental health service will support any stage of loss if you're referred to us at any stage. Bereavement midwife is slightly different, I think. Do you want one of you?
Well, we support families in the gynecological wards, all the way through to neonatal deaths or sadly sudden infant death. Our remit as midwives is up to 28 days, but we've all been talking this morning, we support families for a lot longer than that. And then when they become pregnant again, often with their first port of call, with a positive test, and support for them onwards.
And that's another thing to mention, that again is the maternal mental health service is from any point in pregnancy. So like you say, from that positive test, unlike there's another service in Northampton perinatal team, and that's from 12 weeks. So sometimes people get confused, but we're from right at the beginning. We also include within our pathway complex fertility issues, because for us that's a different type of loss. But where there's never a pregnancy, but perhaps lots of attempts at a pregnancy or IVF that doesn't come to a pregnancy, we would still include that as part of a loss, because that can have very similar feelings associated with it. Okay, next slide, please. So I think one of the things for the maternal service particularly is we are a mental health service, and sometimes that language makes people uncomfortable because they say, well, this doesn't feel like a mental health difficulty. And we think that's because understandably any type of loss is going to have a number of feelings associated with it, and that is to be expected. But there is also sometimes situations in which mental health support is needed. So for us as a mental health team, that's certainly what we're looking at, but that's also why we're working so closely with everybody that's here today and with our bereavement colleagues, so that whatever the need is and whatever support is required, we can make sure that that's in place. But we do expect that there may be initial shock, confusion, it might be interfering with sleep, appetite, having lots of memories of what's happened, being quite preoccupied by the loss, or preoccupied by another pregnancy. And that's where we talked about pregnancy after loss. So some of our mums will feedback that, you know, very soon after they're thinking about another baby or another pregnancy. And all of those things might be things that we do expect. Next one, please. And we also think a lot about grief and about grieving, and there can be a cycle to that. We have lots of discussions that it isn't an expected process, that it doesn't necessarily mean it's going to go this way, it's going to follow this cycle. People will hear about kind of stages of grief, but actually we certainly wouldn't really formulate it in that way. It doesn't necessarily work in that way, because it's not really a linear process. And we also would say that you don't have to experience each part of this cycle or each stage of this to have grieved successfully. So sometimes people will say, oh, I don't feel like I've grieved, and it's, well, what do you mean by that? What part of it do you feel like you're missing? And particularly where there's another pregnancy, that feeling of, well, have I resolved what's happened already, can be really, really apparent. Do you want to add anything there?
Yeah, and I think it's one of those times around when you become pregnant again and the time that's passed since the baby who passed away. You know, some of those past feelings may come up again in another acute, very strong, very powerful way, and it can be a very confusing time when we want to sort of connect with our next pregnancy, our baby, and that sort of sense of then and now can become very consuming and very difficult, and that can challenge how we might feel about this pregnancy and how we still feel and our bonds for our baby who's passed away. And, you know, we might see that in a sense of a continued grieving and bonding process, and of course how psychological difficulties or mental health difficulties may start to impact on our feelings about this baby and pregnancy and our bond with our baby who passed away. So we're sort of looking at both of those elements, really, thinking about how to support you.
So we did think it's important to name the things that we would say are mental health difficulties associated with loss. So we do see people with post-traumatic stress disorder. I would say that's probably the majority of people that we see, where the trauma has become such that it would reach, I suppose, what we call a threshold for PTSD, and that's for both parents that might have been involved in this. We obviously see episodes of depression after loss. And in subsequent pregnancies, antenatal depression is very common.
Yeah.
Anxiety, I think probably the second one that we see the most of, and I see all my bereavement midwife colleagues nodding, and particularly in a subsequent pregnancy, because it's understandable that there is anxiety in a subsequent pregnancy, but that anxiety sometimes can become so big and become so overwhelming that additional support is needed. And we also talk about something that we call an acute stress reaction or an adjustment disorder, which is an episode in which it's very, very difficult to manage, but it doesn't necessarily meet any of the other groups. The other thing we work with in our service, and isn't on here, is we do work with bonding difficulties between mum and baby, or the birthing parent and the baby. because all of these things that we're talking about today can impact on the relationship, and certainly what mums say to us, and maybe to you as well, is I feel like I'm not enjoying it. I feel like this is getting in the way. I'm not able to experience this in the way that I wanted to, and that's something we would support with both antenatally and postnatally as you adjust to new baby.
I think alongside some of that, and I think that may come up in some of what we're talking about here, is some of the guilt that's often associated with next pregnancy, and guilt around how I'm feeling about my baby who passed away. And again, that sort of affects connection with next pregnancy and, you know, connection with ourselves, you know, that we want to be, the parent that we want to be. And I think the thing that we're interested in is sort of, if we think about grieving as a continued process at whatever stage that might be in, because that's our connection with our baby who passed away, and also how depression or trauma reaction and anxiety perhaps can come up in an acute episode again, where we think we may have done some work to work through our feelings of grief before, but when we become pregnant again, or we're thinking about a next pregnancy, some of those feelings from our past can become very powerful again at this stage, and how hard that is to navigate around that world when perhaps the world around us thinks the time has passed enough for us to be okay. And how do we begin to share and make sense of our past reality that's back in our present and is affecting our future?
Yeah.
So if we think about understanding things as depression or anxiety, or just how we're feeling, and how we can begin to organise those feelings and make sense with you, that can help us, you know, move forward with our connection with our pregnancy and how we feel about a baby who's passed away.
Yeah. So we have got information, a bit more information on some of these, and we can send these slides around. That's all right, don't worry.
Never off duty.
Never off duty, no. Always at work. Well,
It is work.
When we say you can get hold of us, we literally mean it.
Yes.
So the other thing I'm going to mention from a mental health perspective, and it is a difficult one, but it is suicide, and thinking about suicide and thoughts of not wanting to be here, or children being better off if we weren't here, or a wish to be with the baby who has passed away. So again, we would say if you're experiencing any of those thoughts or feelings, that's something that we do expect. And it isn't necessarily something that means that, you know, all of mental health services are going to swoop around and be intervening, but actually it's something that we want people to be able to talk about, because it is a risk factor. Baby loss is a risk factor for suicide, and we would want people to talk to us about that. Okay, next slide, Anthony, thank you. And the next one, I think, will go on. So this one, just again, we'll talk about when to seek additional help. And today we're really fortunate to have so many services in the room that are available to help. And I think what I would encourage is finding a service, whichever one feels the most comfortable for you to start with, whether that's approaching a support group, or getting support for a sibling or for a family, whether it's coming to us as a mental health team. But my take-home message would be start somewhere, and find something, because we'll all work together, because we would anticipate it's a roller coaster. And earlier Maggie and Jane were talking about good days, bad days, and really horrible days, and I think what we would expect, and certainly what we see in pregnancy after loss, is there is days that are really good and you are excited and you're looking forward to a new baby, and there are days that are much harder, and sometimes people will say, well, I didn't, because some days are okay, then I haven't come for help, because it's not always like this, but we want to be there for the days that it is, so, you know, however it is, whatever stage of the roller coaster it is. Okay, carry on. We've got some lovely images, and then nobody can see them, so we're just going to skip ahead. So pregnancy after loss, for us, that's from the moment that you start thinking about another pregnancy. And for some people, that's a conversation. You start planning another pregnancy and talking about when you might start trying again. And other people, it's a surprise that there is a pregnancy and there wasn't a conversation beforehand. Either way is fine. We offer preconception service. So if you are having that conversation about wanting to start trying again, you can come and have what we call preconception counselling, and we can give you some advice. Now that's normally a one-off appointment where we talk you through all of the advice and the options. And do you want to say a bit from your side about preconception or planning another pregnancy?
When we meet with people after they've had a loss and we have what we call a follow-up appointment, part of that appointment is talking about, well, what's your care going to look like? What does anything need to be put in place before you get pregnant? So there's usually a plan of what the next pregnancy would look like. And we certainly say to people, when you do find out you're pregnant next time, let us know so we can arrange early scans. But it can also be very important for some people to come and actually have a meeting with a consultant pre-pregnancy. So when you're starting to think about another pregnancy, again, let us know and we can arrange an appointment to discuss what can be done if that's not already been set in stone.
Yeah. And obviously this morning, Maggie and Jen were talking about their pregnancy after loss group as well. So again, there's there's peer support and so on available as well. And we might also think about, like Trudy was just talking about, continuing bonds with baby who's passed away. Okay. The other thing that I know I spend a lot of time on in my work, and I'm sure my colleagues are the same, is how to deal with, we're going to call it the outside world, how to deal with everybody else, communicating with other people, understanding how people are communicating with us. But also, and I had this conversation with a mum yesterday, not taking responsibility for other people's communication or the way that perhaps they're dealing with things, and trying to negotiate this in a way that works for you as the person who is pregnant and is going to have this baby. And I think that can be a really tricky process, and some of those conversations, even sometimes do role play or helping people work out actually how am I going to do this and what would it be like, and having those different different use of language, I guess, that can be helpful.
I think the outside world as well, when people are out there and their lives are carrying on, and we know that, but also when those people around us who are in our world who aren't saying anything to us as well, and that can be equally as difficult to what sometimes people are saying or how people are with us. Yeah. So it's thinking about all of those elements.
We also will try and support with the outside world that I guess we are a part of in terms of the professional world. So we try very hard to support things like we will support birth planning and preparation. We're trying to do some work with sonographers at the moment about those questions of, perhaps not saying, oh, is this your first one? Or those things that get said and actually can be really, really difficult. So we try and work with our professional colleagues to make sure that when people are coming into hospital, be that for a checkup, be that for delivery, be that for whatever, that we're working with everybody to what we call, make sure your care is trauma informed. That's what we call it, that everybody's trying to bear in mind what your needs are, and hopefully minimise the potential of further distress or, worst case scenario, further trauma. So probably if we go to the next one, I think that will be easy because that's got all the stuff on it. Yeah. So do you guys want to talk about what's available? Yeah, you have to read it from them.
So this is really just a little bit about what our roles are. And I think what the most important thing to say, it's focused support, it's very individualised support for families. For every family is an individual, the circumstances for the loss are very different. And we work with all the families on an individual basis and their individual needs. And that is probably one of the most important things. And our support is, we provide people with timely and relevant information at the time of the loss. Our role, I think both of our services, we generally are in contact with people from 12 weeks and onwards. Prior to that, the gynecology department do offer support to people, but we do get referrals from people that are earlier than that, and we often give them our numbers, and we do say we can speak to you. If they do want to contact us for any support at any time, we can be available. But also we will signpost them to the SANS groups as well, and the SANS helpline. They are very, very helpful. We can help with making sure people get results of any investigations that are done. We give them guidance on arrangements that would need to be made in terms of registrations and funeral options. And again, it's ongoing emotional support. As Carolyn said earlier, our remit in theory as a midwife is up to 28 days, but very rarely are we in contact with people for only 28 days. Realistically, we are in contact with people for much, much longer, and often it's years and on into the next pregnancy and to the future as well. I mean, certainly I've been in post for 7 years, and I'm off and on will still be in contact with people right from 7 years ago, and even prior to that when I worked with the previous bereavement midwife in Northampton. So there is, people often do say, well, how long can I contact you? How long will you be there for? And I always say to people, this phone that we have, your number will never ever be deleted, so do not ever worry about contacting us and reaching out, because I think we, being the people that are there in that moment, in that acute moment when the loss has happened, I think we have an additional depth of understanding. We've walked the journey with them, so they don't necessarily have to explain everything that's happened, the circumstance of what has happened. We have that understanding. So we can always be there for as much or as little as people want. And again, we always say to people, we'll go alongside with you for as much as little. We're not going to intrude on your time. Everybody has a different family support network, different set of circumstances, as I said before. So we will really tailor to what the family want. And that's one of the most important things, I think. One of our roles is to help with the reporting of losses to more national groups and investigations that happen afterwards. And again, feeding back to families about any of those outcomes, if there's anything important to share with them. And we do support other staff members. That's within the hospital. We work very closely with the SANS and SANS are the external charities. They're absolutely brilliant. I cannot thank them enough for everything they do, providing us with memory boxes and the support groups. Obviously, we've got the monthly support group, as Maggie was saying earlier, and the next pregnancy group that's just restarted face to face, and that's absolutely brilliant. That's such a fantastic support for people in their next pregnancy. At Northampton, people normally see their usual community midwife at the community midwifery hub, and that's very good. But we're also still in the background to support people in their next pregnancy. I know Caroline and Lisa have a specialist rainbow clinic, which would be absolutely wonderful if we could offer that in Northampton. We hope that we will be able to do that. I think mine and Rachel's hours are increasing, so this may well be something that we're able to offer in Northampton, which would be absolutely brilliant. But I'll hand over to the lovely Caroline and Lisa to share about what Kettering do in terms of their next
We've
pregnancy.
had such amazing feedback from having that rainbow service, so we're very proud that we've been lucky enough to be supported in doing that. And it is, Carolyn was there at the setup and she supports all the ladies through it. But the families, to have a team that's a small team that they see at every appointment. If they have a scan, it's scheduled, so they're going in to see the consultant straight after. And it just gives them, their anxiety is heightened, obviously. So it just helps to alleviate some of those anxieties. They're not walking into a stranger. They're not going to be asked a question, is this your first baby? Because we know them. So I'll let Carolyn expand further on the rainbow.
Well, we see families following a stillbirth or a neonatal death, so roughly around from sort of 24 weeks gestation, and sadly if they've lost their baby once their baby's been born. And as Lisa said, we have a really lovely team. There's just 4 of us. There's Lisa and myself. Lisa generally is very kind and covers for holidays, and then we have an obstetric consultant called Mrs. Adcock, and we also have a specialist registrar who also supports in clinics. So it's just the 4 of us. So we get to know them and they get to know us. Often we've seen them if they're a Kettering lady. with their bereavement. So we know about their baby, and that's really important. And we've had really lovely feedback, as Lisa said. Really, it's the continuity that they know we're not going to ask them awkward questions when they come in to see somebody they've never met before. And we work with the maternal mental health services if it is a lady who's been referred to them for birth planning. We do bend the rules quite a bit, don't we, Lisa, when it comes to visiting, and in COVID times it has been quite difficult because partners haven't been allowed in as much as we wanted. But for our Rainbow ladies at Kettering, they have been really accommodating, and I know the team above us has allowed a little bit more access, which is really important, because then when they come to appointments and come to the time that they're either being induced or come in for a cesarean section, we don't want them to be on their own. So that's been really good. I can't think what else to say.
It's all right. So I think that the best thing ever is when you've helped somebody through a next pregnancy and they're in hospital and they've delivered and you get to go. It is the best. It's absolutely wonderful. I've done that this week and it's been absolutely amazing. We have some amazing knitters who knit us things for babies, but we get also rainbow blankets. And we go and take them a rainbow blanket, and they're just absolutely wonderful. And it's just so wonderful to see people. And obviously we will still then keep in contact with people even after then. And that's absolutely wonderful. And it's just such a wonderful job. It really is, to have the privilege of being able to support people. It's absolutely amazing. It really is.
So I'm mindful of time, but I'm just going to give you an overview of what we do as well in maternal mental health, and then probably be lunchtime for everybody, I would imagine. So, obviously there's a huge amount available in Northamptonshire already, and people who've worked very, very hard for many years to ensure that this support is there. But what became apparent when we launched the perinatal mental health team is that actually, as a mental health service, we had a gap for women who had experienced loss and who'd experienced birth trauma, and that we needed to be able to provide specialist psychological support to those women who needed psychological therapy, really, in addition to perhaps whatever else they were accessing. So we got some funding for that. We were one of 10 pilot sites for the whole country to launch this service and start running it. And we've run it for a year. And like everybody else, we're small. There's Trude and I. We've got Jess as assistant psychologist, and now 2 midwives about to come into post. But we are small. And what we offer is psychological intervention, basically. So for people who are in a subsequent pregnancy after a loss, we run a trauma, it's called trauma stabilisation, but it's a trauma intervention group during pregnancy to enable people to have a good understanding of trauma, how that might impact them during pregnancy, how that might impact on their delivery. And they would have that session. Now it's a group, and sometimes psychological interventions, when you say, oh, it's a group, people will say, oh, I'd rather have one-to-one. But actually, I think today, being in this room together and hearing from everybody, we can see the value of doing this in a group. And we do find that it is very, very helpful to be with other women going through this similar experience. So we run that. And then as part of that, we do what we call birth planning and preparation, because planning is a bit of a misleading word, but we haven't thought of a better one yet. So any suggestions, do let us know. So that's an appointment where the family, often a individual and birthing partner, will come to an appointment with normally me and one of the specialist midwives, and sometimes bereavement midwife or whoever else is involved, and we'll spend time putting together a document to support this person through their delivery, including all of the things that are likely to be particularly difficult. So sometimes that they don't want to be in a certain room in the hospital because that's where they delivered before, so we'd aim for a different room. It may be that there's certain, it can be anything, sounds, smells, things that they can see, anything, and we're trying to make sure that as far as possible we minimize the chances of certain things happening again that's likely to increase distress. We do that, and then obviously we see them after they deliver. Unfortunately, we don't tend to see them quite as early and get the baby cuddle, but we do see our families after babies come, and then at that point we reevaluate what's needed. And for some people, they need postnatal intervention, and if it is following a subsequent pregnancy, then it might be a parent-infant intervention. It might be something to do with them and their new baby. It might be peer support. It might be that they still need a one-to-one trauma intervention, perhaps, again, maybe to do with what's happened previously or what's happened this time, depending on the experience this time. And we also do intervention for individuals, obviously, who have lost their baby, so there isn't a baby at that moment in time, and they need some psychological support around that. And like everybody else, we do our best both to meet everybody's need and stay within what we're commissioned to do, but also do find that we bend some rules sometimes. So that's what we do. Okay, I think I've been through all of that. Thanks, Anthony. Yeah, we'll carry on. I think I've just talked to about 10 slides. So there is feedback on some of these things, but again, I think that it would make more sense for people to be able to see the slides, like, you know, because these will go round. And then I think we go on to questions. So the final thing I think I'm going to mention is partners and fathers. You know, like lots of people, we're here predominantly talking about often mother or the woman, or for us the birthing person, because it isn't just women and mothers who may be pregnant. We also would support birthing people, however you identify. But we get asked a lot about partners. Like I said, we're commissioned for the birthing person or the mother. So that does mean that what we can directly offer partners is limited in our service. However, we do offer couple support. So we do a fair bit of couple support, particularly for parents of neonates. I do a lot of that neonatal work. But we also work really closely with IAPT, who are here today, to offer support for fathers or partners who may have experienced trauma. We're in the process of looking at a dedicated peer support pathway and access for fathers, and there's some projects going on around that, and working alongside, you know, the organisations that are already there, so things like Daddies with Angels and obviously SANS that we've already talked about. But that's the other thing we get asked about quite a lot is fathers and partners. So I think, unless there's anything to add, that's our. But yeah, open to any questions. I suppose the only thing I didn't cover is how to get referred, isn't it? Yeah. So if you do want to access us, it's through your GP, health visitor, midwife. They will make the referrals to us. You can't self-refer to us, but if you were struggling to get referred or you weren't sure how to ask, I would say ring us and we'll tell you how to get referred, or we'll make sure that somebody refers you in. You can't technically do it, but if you're stuck and you're not sure, do ring and let us know. But yeah, any questions?
Can I ask if we got someone in our group about your service, if they then got to go to their GP?
I would imagine we could take a referral direct from yourselves, but I will double check that.
And is there a waiting?
For assessment, our waiting times are within 6 weeks. We aim to see people within 6 weeks for an initial assessment. That's in a situation where the person isn't currently pregnant and doesn't have a baby under 1. If the person is currently pregnant or does have a baby under 1, then it's 4 weeks, and that's because they may be eligible to access the perinatal mental health team, because there's 2 teams in Northampton, and obviously I've focused just on the one today, but I can tell you about the perinatal team as well if you want to know about that. So for assessment, no, there isn't a huge waiting time. For intervention, it depends on what is needed. So the antenatal groups we run really often. So the majority of individuals that need that group will go through that group. If they come at a point at which there isn't a group, so the timing just mismatches, then we try and deliver something one-to-one. So an abbreviated version, basically, so they still get some support antenatally. But I suppose, again, the take-home message is refer early, because if we get a referral at like 36 weeks of pregnancy, then obviously at that stage it's really difficult to offer a 6-week group.
I think it's fair to say as well, the assessment process, whilst we call it an assessment, you know, we offer around 2 hours, and that includes, you know, psychological understanding to what's going on. So we really take time to try and help, you know, think together about what's been experienced, how it's impacting what's going on. That's going to include, you know, some, you know, understanding, some psychological education, and often we'll do some resources within that time. So we're always looking for opportunities to help, you know, manage and work through difficult feelings. Often the assessment process itself is very emotive. So, you know, we might need to sort of begin to do some of that work at assessment as well, which is why we allow, you know, while we provide the amount of time that we think is going to be helpful without it feeling too long or too much, and to go through things. And quite often for some ladies, it often means a second assessment if we're unable to complete that in the first, because as we know, you know, it's a very emotional time, and we can't always think through and understand the needs in that first appointment.
Like an assessment could be anywhere from 1 appointment to 6 appointments. So although we're saying assessment, it's not like a half an hour phone call or something.
We really do want to think about what's going on.
Take a good chunk of time. And then in terms of postnatal one-to-one intervention, that probably is where our waiting times are longest. But they're still nowhere near the kind of scary waiting times that get put in the newspapers, that you're going to wait a year or 18 months or anything, because we're commissioned to work up to a year. So we need to have seen and completed the work within that time.
Because a lot of some people who come to group will go to the GP, and the GP will give you counselling, and then they're on a waiting list. And it's like they've asked for help and they want it now.
And I think
they don't get it, and I think they get despondent. My only thought might be, I said, well, we've got the maternal mental health and the mental. I'm not mental. And you're saying I'm, you know, I'm a psychiatrist, and so you've got to get over that. Barrier.
And we've had this. We keep having this debate about whether we're named the right way or whatever. But we are a mental health service, not because people are mental or because they're going to get carried away, and we don't have psychiatrists. You know, we're a psychology-led service. But although all of these things are to be expected, having experienced a bereavement, sometimes the levels of distress do fall within a mental health remit, and that is something that you need mental health support for. So it feels like this, and again, I guess because we've been going a year, and this is where we're trying to raise everybody's awareness that we're not a counselling service. You know, we're a specialist mental health team that can provide you with specialist intervention to support you and to support families. But I also think that we can't shy away from talking about mental health in relation to these things, because when we do look at things like suicide and some of those areas, that it's that balance, isn't it? I think when a week like this that's about raising awareness, we've got to be willing to raise awareness of it all. And if there's parts of it where we're going to, well, maybe we won't call it mental health, maybe we won't use this word or tell this story, or then I wonder how helpful that is. And I think for us, some of what we do is mental health. And I hope that if people need that, then that can be okay to need that.
Do you agree with me? Some people with fencing But maybe it's not what they needed really.
Yeah.
And they sometimes feel that the counselling hasn't actually done them any good. No, group said it's a waste of money.
Yeah.
They didn't listen. They didn't understand.
Yeah.
And I think they've got to find somewhere where they're accepted and you get it, if you know what I mean.
Yeah.
And I think the thing, particularly with, say, PTSD, if somebody has post-traumatic stress disorder, then sometimes counselling or debriefing, which can be very helpful in certain circumstances. If you have PTSD, the nice guidance and recommendation is that you don't have something like a debrief, because actually that can make you feel re-traumatized from that. So for somebody who needs to make sense of their experience and is not experiencing a mental health difficulty or post-traumatic stress disorder, very helpful experience, very containing experience. For somebody with PTSD, we would be advising against it right now until you've done a piece of work around managing that post-traumatic stress, basically. And like you say, I think it's the right interventions at the right time. And, you know, 2 years ago, this service didn't exist, so it would have been hard to know where to go. And I think we all try and find the best service that we can for somebody with what's available. And you know, it's nice to be here today and kind of just say, well, we're available now, and hopefully that will help.
I have a question. What interventions do you use when you see families? Listening therapies or CBT?
So we're true to CBT therapist, an EMDR therapist,
An IPT therapist,
an IPT therapist, and
a mental health nurse.
And a mental health nurse. So I would say, yeah, our nice recommended interventions are trauma focused CBT, and EMDR. Do you want to say a bit about EMDR for people that don't know what it is?
So EMDR is eye movement desensitization reprocessing therapy. So it's a type of therapy where we use a particular type of approach, call it eye movements, where we create bilateral stimulation to try and process the physiological, visceral feeling in the body that can often contribute to, you know, difficult thoughts, difficult memories, difficult feelings can get stuck in our physiological system. And that means our, you know, here and now perspective or our helpful thinking can get stuck. And so the memories that we've experienced feel like they are staying in the sense of it feels like it continues to happen. So an EMDR process works on quite a lot of the physiological distress that's related to the experience and the emotion that keeps the trauma going. So it kind of moves that through our physiological system to enable our thinking and our emotional system to sort of become more here and now in how we want to understand our past experiences. And trauma focused CBT therapy does something similar, but it's the method of how you're working with the memory that is done slightly differently. And both have got a very good evidence base, and often in the end it comes down to what's going to work for the person. So that assessment phase, that preparation phase, helps us get to know the person, the woman, they get to know us, and we can make decisions together about what processing method is going to suit best and how we might use time and the therapy space to be able to do that focused piece of work. In terms of working on memories. Interpersonal therapy is a depression focused treatment most of all, but it has a focal area of grief where we can work on that emotion and sense of self in a talking way, in a focused way, to help with that transition in terms of treating the depressive symptoms that's keeping the grieving acute and perhaps even stuck. To sort of move that through. And often, you know, I think we've all been talking here today, you know, in all of the sessions, it essentially, I think what all of talking treatments are about is the relationship that you have with the person that you're working with.
Yeah.
And I think that's why we're so interested in understanding what's happened and working with the woman's and the mother's sort of sense of this is what they think they need. So we're listening for that as well.
Yeah.
And at the same time, we're starting to think about what their needs are to reduce the intensity of that distress or lift the depression, to help them, achieve that sense of they can carry on in that new normal, however scary that and overwhelming that still may feel. And I think that's an important understanding to reach, that it's still going to feel difficult. Yeah.
And
it's
sometimes I
unknown.
get it, it's like other people are ready, got to accept the new person. They can't accept the old person back. And that comes into the group quite well.
It does, and and the world still carries on, as we've talked about the outside world. Yet, how do I relate to the outside world feeling as I do?
Yeah.
So, your question around, what therapies are out there, what do we do? So I guess the distinction between we will do a focused piece of work that's often sits within other things that are going on. With midwifery services, with support services, with counselling services, with that sort of, rebuilding and trying to reassemble in a more organised way with things that feel so disorganised and chaotic and messy.
Yeah.
And trying to find language for that.
And in addition, so we've got that, but as clinical psychologists would be trained slightly differently, so still do trauma focused CBD, and we've got some psychologists who are also EMDR trained, but I'm emotion focused couples therapy trained. So in terms of this service, my work is more around the couples and working with both people to try and process some of that. And we also do quite a lot of narrative work, and thinking about how this current experience may relate to past experiences, and that might be. I was talking to Harry's Rainbow earlier, and they were talking about, it might be that you lost a parent a long time ago, and now you're pregnant for the first time. So the loss may not actually be a baby, or it might be, and those things can come up in psychological therapy in terms of what is it that we're trying to construct here and make sense of. But whatever we do, it's always with the individual in mind and trying to find what works for them. And we're fortunate to be in a position where we've got a range of things available. Thank you. Any other question?
How do you know what's normal? And how do we know that we need something like your service?
I think one of the things that I tend to sort of bring into that question, and it's always a question that's in mind when we're sort of, supporting the sort of narrative and making sense. And I think we look for things like, how long has it been since a baby who's passed away, and that experience, and how it's impacting on everyday functioning, and I think there are sort of specific symptoms like, is it remembering with strong emotion, or does it feel like it only happened yesterday all over again? So that acuteness has come back in terms of, the thoughts, the feelings of the experience they had before. How distressed are they? Are things happening when they least expect it? So these idea that images, body feelings, pictures, and that real sense of that it feels like it's happening all over again, and therefore how they're coping with appointments, cooking tea, going to work. So the impact on that functioning. So we look for intrusion. So that's a specific symptom associated with PTSD. The physiological impact that could be on. So how much is that impacting on their body reactions? How much are they avoiding or suppressing talking about or being with those memories? So they're just unable to cope with what they are going through again, and how that's then affecting how they're connecting with their everyday lives and perhaps next pregnancy. So levels of avoidance as well. So we look for those sorts of things, or depression type symptoms, you know, that level of just not being able to manage every day and feeling, you know, it's more than sadness, lack of enjoyment, you know, difficulties with motivation and energy and social connection, often feeling very disconnected and outside of every day. And how concerned are they about how this is affecting their everyday life?
And so people will say things like, I don't feel like I'm here. I don't feel like other people get it. I don't feel connected to anybody else. Sometimes it's I can't stop thinking about it. Sometimes it's I can't remember it at all.
Yeah.
I can't think about it at all. But a lot of the time it's just a sense of people just come and say, I need some more help. And they don't know why, and they don't know what with, and they don't know what's different. But sometimes people just kind of know. And sometimes that for us, that's enough. And then it's our job to help work out why they feel that way, why they have this sense that they just need a little bit more. And that's okay too. And we say this to families as well, like sometimes it's a partner and just rings us up and goes, they need a bit more. And whenever we've done one of these events, somebody rings up. The first one we did, somebody rang up, it was a mum of a mum. And she rang up and said, my daughter needs some more help. And she did, and she was right. And none of the family knew why or what they needed, but they were right. And that's that.
And we often hear that sort of sense of I just feel stuck again. You know, that comes up a lot. And I think, you know, this idea that if we can sort of work on some of those sort of more active symptoms that have come up again, then the grieving process continue, because we know it's a lifelong, you know, experience because of our relationship with our baby who passed away. And of course we want that connection with our baby to continue quite often, and so some of these distressing symptoms get in the way of how we want to be with our baby who's passed away, and how we want to be with our next pregnancy, and so on. So that sense of I'm just feeling stuck again is often what we hear, and that's the conversation that we start.
Yeah, that's the starting point.
That's the starting point.
I'm going to let us finish there because I'm sure people are ready for lunch and all of those things. But if there's more questions, you want to talk to us one-on-one or whatever, obviously we're here, you can do that. But yeah, thank you all for your time.
Yeah.